Resume. Oh, bless her, not press her like this. Maybe like us. Okay. This time I'm gonna record and finish. I'll let you know. Yeah? Okay. Okay. Let me see. Thank you. Okay. Okay. Other bacterial infection. My name is Sylvia Muta. I'm going to be speaking on cholera infection, biology of cholera. Cholera is cholera, a devastating diarrhea disease, is caused by Vibrio cholera, a gram-negative bacterium. This pathogen produces cholera toxins, triggering preformed water, diarrhea, and dehydration. Understanding interplay between the V. cholera and its toxins in pivotal from addressing the disease severity, World Health Organization 2020. Celans et al. 2017. Characteristics of virulence. Pathogenicity. Cholera pathogen center on Vibrio cholera, a gram-negative bacterium. At the heart of its variance in the cholera toxins, a complex AB toxins. The base summit, some units facilitate attachment to intestinal cell, while the subunit activate isolate glycate inducing glycic. Have production, this disrupts iron regulation, leading to profuse watering, diarrhea, and dehydration. V. cholera's rapid colonization ability to form biofilm and efficient toxin dissemination contribute to its pathogenicity. Harrison et al. Characteristics of virulence of cholera. Cholera toxins, one, structural cholera toxin is a multimeric protein with A and B subunits. Two, mechanisms of actions. Attachment B subblind to intestinal epithelial cells. Entry a subunit. Entry this cell, activating hydroxylate glycase. Glycate AMP production results in elevated glycate AMP level, causing iron secretion and watering diarrhea. Virulence characteristic. Rapid colonization. V. cholera rapidly colonizes the small intestine, enhancing toxins production. Toxin dissemination. Cholera toxin is secreted, affecting a wide area of the intestine, leading to massive fluid loss. Biofilm formation. Cholera can form biofilms, adding in survivor and persistence. Disease description. Organs affected and mechanisms. Primary impact on the small intestine. Vibrio cholera colonize the small intestine, epithelial cells, releasing cholera toxins. Cholera toxin induce uncontrolled secretion of electrolytes and water. Common signs and symptoms: severe watery diarrhea, vomiting, dehydration, leading to electrolyte imbalance, muscle cramp. Stages and development of cholera. Incubation period takes between 12 hours to 5 days post-exposure. As metastatic carrier stage, some individuals carry this bacterium with start symptoms. Acute stage, sudden upset of profuse diarrhea, vomiting, and dehydration. Proteolysis, critical administrative dehydration therapy promptly. Untreated cases can lead to rapid, severe dehydration and death within hours with timely intervention. prognosis is generally good. Transmission, how cholera is being transmitted. Cholera is primarily transmitted via the fecal oral route with contaminated water and food serving as a major factor. Poor sanitation exacerbates transmission and the bacterium can persist in aquatic environment. In densely populated areas, person-to-person transmission is significant, included by symptomatic carriers. Cholera outbreak are closely linked to compromised water supply and inadequate sewage system, according to World Health Organization. Contagious nature. Cholera is highly contagious with rapid transmission potential in communities. Asymptomatic carriers unknowingly contribute to its spread. Key consideration. Cholera can persist in aquatic environment. Outbreak often linked to contaminated water supply and inadequate sewage system. Treatment for cholera. Rehydration therapy. Oral rehydration solution, ORS, is the mainstay of treatment. Intravenous fluid for severe cases to address dehydration. Antibiotic therapy. Disocycline, disocycline, disocycline or azithromycin might be prescribed in severe cases, reduce the duration and severity of symptoms. Supportive care. Electrolyte replacement to correct imbalance. Nutrition support for recovery. Key consideration. Timely intervention is crucial to preventing complications. Prevention of cholera. Vaccines vaccination. Oral cholera vaccines such as Shaquille and Vaxcola offer effective prevention measures, particularly for travelers and in risk of population. Water and sanitation, ensuring access to safety water resources and improving sanitation infrastructures significantly reduce the risk of cholera transmission, according to World Health Organization. Hygiene education, promoting hand hygiene, safe food practice, and educating communities of cholera transmission, preventing and pivot in controlling outbreaks. Surveillance and early detection. Establish robust surveillance system and implementing early response strategy are essential for timely outbreak identifications and contaminants. According to World Health Organization. Introduction and theology of C. difficile colitis. Consider difficile colitis is a significant healthcare associated infection affecting the colon. C. difficile colitis arises when the delicate balance of gut microbiota is disrupted, often triggered by antibiotic use. Clostridium difficile, a spore-forming bacterium, in the primary culprit behind C. difficile colitis. These gram-positive anaerobic produce toxins such as toxin A and B that damage the colonic mucosa, leading to inflammation and diarrhea. Antibiotic therapy, especially broad-spectrum antibiotics, disrupt the normal gut flora, enabling C. difficile overgrowth, Kelly and Lemont. Pathogenesis. Colledrum difficile C. difficile is a gram-positive spore-forming bacterium responsible for antibiotic association diarrhea and colitis. Its pathogenicity is primarily attributed to the production of toxins. AT, TID A and toxin B, TID B. These toxins disrupt the colonic epithelium, leading to inflammation and tissue damage. Virulence. So receptors of colonic cells, causing inflammation and fluid secretion. Toxin B, cell B, destruction and acting like glycoselectin of host cells, induces cell death and tissue damage. Spore formation. C. Dactylitis forms spores, allowing survival in the environment and resistance of harsh conditions. Disease description. Organs affected and mechanism. Primarily affected the colon, large intestine. C. Deficient spore germinate, colonize the colon and release toxin. Toxin A and B disrupt the colonial epidemic, leading to inflammation damage. Common signs and symptoms. Watering diarrhea often occur multiple times a day. Abdominal pains and cramping, fever, and loss of appetite. Disease description, stage and development. As one carrier, some individual carry C. Delicia without symptoms, mild to moderate infection, diarrhea, abdominal pains, and discomfort. Several infection, profuse diarrhea, colonial inflammations, and potential complications like cytomembranous colitis. Pathogenicity. Patho Pathogenicity varies. Milder case may resolve the appropriate treatment. Several severe case can lead to complication, including toxic uh, megacolon, require intensive care. Reoccurrence is possible, emphasizing the need for careful management. Transmission. Chondral deficit is primarily transmitted through the facial oral route, sparse held in physics and persists in the environmental contamination surface, and health sector transmission occur through the injection of spores, often facilitated by inadequate hygiene practice, contamination surface, or associated factors like improper antibiotics use. Psoriasis et al. Contagious nature. C. difficile colitis is considered moderately contagious, while person-to-person transmission is not as direct as with some infections. The persistence of spore in the environment make healthcare facilities, especially hospitals, a significant source of transmission. Treatment. Antibiotic therapy, first-line metronidazole or vancomycin for mild to moderate case. For severe case or reoccurrence, vancomycin is often preferred. Faca microbiota effective for recurrent or refractory case, involving introducing healthy donor feces to restore gut microbiota, supporting care, dehydration, and electrolyte management to address food loss. Discontinuation of the inserted antibiotics is possible. Surgical intervention reserved for several cases with complications like toxic mecolum. Prevention. Antibiotic stewardship. Prudent use of antibiotics to minimize the spread of gut microbiota. Infection control measures. Strict hands to hands hygiene protocol in healthcare setting. Isolation precautions for infected individual. Environmental cleaning. Effective cleaning and disinfection of surface to prevent spore transmission. Probiotic, considering of probiotic to maintain healthy gut microbiota. Physics microbiota transplant consideration for recurrence case exploit as adequate and prevention secure. And my references. Thanks for listening.